Good evening, everyone. If you can just let me know in the chat that you can hear me. Testing 1, 2, 3. Testing, testing. Genesis, welcome. Sapphire, welcome. Mercedes, Vicky, welcome. Bella, Nikki, welcome. Testing, testing. Genesis, Sapphire, Mercedes, welcome. Vicky, Peacock, Bella, welcome. Nikki, welcome. Today's topic is going to be urinary incontinence, and I'm ChicagoDLSinc, and I do one-on-one as well as group tutoring sessions. And hopefully, um, over the weekend, I'll finalize group tutoring sessions, the timings, and the topics, and we can do a hop in, hop out starting next week. So, if you have any questions, if you're new, save them for the end, and I will gladly address any questions about the presentation. Tara, welcome. Presentation questions, Naplex questions, MPJE questions, or just questions in general. Tony, welcome. We'll give everybody another minute to connect. Hope you're having a good Thursday so far. Right. So, once again, the topic today is urinary incontinence. We're going to cover two topics in this one. One is overactive bladder, known as OAB, and that can present with urgency with or without continence and is defined as a frequency greater than 8 during waking hours and greater than 2 during nighttime, which we define as nocturia. Now, a hint for y'all, if you ask someone how many times they've used the bathroom during the day, they probably cannot remember. But if you ask them how many times they had to wake up at night to go, they'll most probably remember. So, a nocturia is a better indicator. However, some patients may give you a history of, I feel like I'm going every hour. All right. Now, urinary incontinence is the involuntary leakage of urine. Different categories. We have urge, we have stress, we have mixed, we have functional, and we have overflow. Many patients end up dehydrated because of decreased fluid intake, and um, and so you have to keep that in mind when treating patients with this condition. Overactive bladder is due to the inappropriate stimulation of muscarinic receptors of the detrusor muscle, and this leads to involuntary contractions. The M3 muscarinic receptor is responsible for emptying contractions and the involuntary contractions. Can anyone tell me how many muscarinic receptors there are in the chat? Anticholinergics inhibit effects of acetylcholine on the M2 and M3 receptor. Once again, the question is, how many muscarinic receptors are there? Or are you familiar with? Now, while we wait for some answers, the risk factors for OAB or overactive bladder, age greater than 40 years, diabetes, prior vaginal delivery, obesity, neurological conditions, hysterectomy, and pelvic injury. All right, I have a couple answers, and yes, it is 5M1 through 5. Good job. Drugs that can increase incontinence are alcohol, cholinesterase inhibitors, diuretics, and sedatives. Does anyone know any names of cholinesterase inhibitors? All right, anyone else have any guesses for cholinesterase inhibitors? So we have donepezil, rivastigmine, galantamine, and I'm going to check on physostigmine. Vicky, you are correct. Physostigmine is a parasympathetomimetic agent, and that makes it an anticholinesterase drug. Great job. Great job. All right, continuing, we have non-drug treatment options. And behavioral therapy is our first line. We have bladder training, scheduled voiding, pelvic floor muscle exercises or Kegels, fluid management, and dietary changes, which include avoiding caffeine and other bladder irritants, and weight loss if obesity is the cause. Now, schedule voiding is exactly how it sounds. Excellent. Welcome, Mr. Turtle, Suspicious Bunch. Welcome. What you're going to do is you make a voiding schedule or a schedule for when you use the bathroom. On the right, you'll see a picture of the bladder anatomy. On the left side, it's empty. We have the ureter, the muscle, the ureteral openings. They're not marked very well, but basically where the line ends, there's two of them, one on the left and one on the right, which lead to the urethra. You have the bladder mucosa, and you have the trigone of bladder, which is what causes the spasms or normal functioning, um, along with the bladder neck and the urethra. Next, we have drug treatment guidelines. You want to do a trial of 4 to 8 weeks for maximum effect before you modify any treatment or add any adjunct medications. Long-acting anticholinergics such as oxybutynin, extended release, or a transdermal oxytrol are first line. The reason we use the long-acting agents, they have less side effects, but they can cause cognitive impairment. There are selective anticholinergics, and we have darifenacin and solifenacin, and they have less cognitive side effects. The anticholinergic and antimuscarinic drugs are going to be a note about them is the Beers criteria recommends avoiding in above 65 due to risk of delirium and cognitive impairment. Now, you do have to balance the risk and the benefits because many patients who need these medications are going to be elderly. So please keep that in mind. All right, some treatment options for overactive bladder. Uh, we'll start with the anticholinergics or antimuscarinics. And for those that can't tolerate them, there is an option or a class of drugs called beta 3 adrenergic agonists and mirabegron or mirabegrin. I always use the disclaimer, we're not being tested on pronunciation, is an option. So some of the anticholinergics, as well as their brand names, are going to be oxybutynin or ditropan. It's available in tabs and extended release form. There's a syrup. The transdermal patch, which I talked about earlier, you use twice weekly oxytrol, and then oxybutynin gel or gel neek 10% used once a day. You have darifenacin, which is Naplex, extended release tabs, solifenacin, which is Vesicare tablets, fesoterodine, which is Toviaz, available in extended release tabs, tolterodine, Detrol, tabs. There is also long-acting or extended release, Toviaz, and long-acting Detrol. Both have the same active metabolite. For both of these medications, do not exceed 4 milligrams for Toviaz or 2 milligrams Detrol long-acting in patients taking strong CYP3A4 inhibitors. Last but not least, trospium tabs. And they're also available in caplets in the extended release form. Just a reminder, if you're new to these, Melissa, welcome. Tumi, welcome. If you're new, I use RxPrep and Pass Naplex now for my resources. This is not meant to be a comprehensive review. Both are excellent resources, whatever you're using to study. And make sure that if you do some practice questions and feel like you're unprepared or underprepared, go back and augment those, either resources. All right, next we have um, the beta 3 adrenergic agonists. You have mirbetriq or, excuse me, allergies are still kicking my butt. Mirbetriq or Gemtesa, and that's mirabegron or Vibegron. Vibegron. The efficacy is seen within 8 weeks of treatment. The dose is going to be starting at 25 mg PO once a day, increasing to 50 mg. If there is renal insufficiency or hepatic insufficiency in the moderate category, the max is going to be 25 milligrams once a day. And if there's severe kidney issues or liver issues, it is not recommended. The adverse effects are going to be headache, nasopharyngitis, UTI, increased heart rate, and hypertension. Now, I think it's always funny with this class of drugs, it's not recommended in severe uncontrolled hypertension. So it can cause hypertension, but if you already have it, you're not supposed to recommend this. It does have less constipation compared to anticholinergics. Now, a drug interaction I want you to be aware about is mirbetriq is a CYP2D6 inhibitor. It increases the substrates, and three of them are listed: flecainide, propafenone, and thioradazine. Can anyone tell me what flecainide is in terms of class? In the chat, go ahead and put your answer. It also increases digoxin levels. It reduces levels of tamoxifen, codeine, and tramadol. And as a follow-up question, if you're not sure, or even if you do know, can anyone tell me any brand names for tramadol? So first question was flecainide. What kind of medication is that? What class? And for tramadol, can anyone tell me any brand names? All right, getting some answers coming in. And it's okay if you don't know. Remember, these sessions are supposed to be where you can learn, or if you've already reviewed this material, know, hey, I have some gaps in my knowledge base. Let me go back and review these. Good. So I'm getting some brand names. Ultram is one. Sapphire, you are correct. Good job. Antiarrhythmic 1C. Good job. And I would have expected, not expected, I would have accepted antiarrhythmics. Vicky, are you going to share a mnemonic or are you asking if there's a mnemonic? Oh, that's a good question. Does anyone have a mnemonic that they can share? And if not, I'll look for one and I'll share it with you. Great question. All right. So the next slide is going to be about Botox, botulinum toxin A as an alpha. I always like to make the joke about Wi-Fi passwords. If you choose botulinum toxin A, I will use my data. Thank you very much. This is a third line treatment for refractory patients, but it does have a higher efficacy compared to anticholinergics and the beta 3 adrenergic agonists. The mechanism of action, it decreases detrusor muscle activity by inhibiting the release of acetylcholine. The dosing, each dose is 100 units total, and it's administered as 0.5 ml, which has 5 units, injections, given into the detrusor muscle at 20 different sites. You can repeat every 12 weeks. Now, this next point is important. The maximum Botox dose every 3 months is 360 units all over. So if you're getting facial augmentation or bladder injections, wherever you're getting Botox injections, every 3 months you can only have a maximum of 360 units. Quick math question for you. If it's administered as 0.5 ml for 5 units, how many ml is 360 units going to be? Once again, 360 units of Botox administered as 0.5 ml for 5 units. How many ml will that be? Everyone hear the question? Oh, there might be a bit of a lag. Okay. Once again, 360 units. And if it's 0.5 ml for 360. All right, got some answers. And 36 ml is correct. Great job. Great job. All right. Boxed warning for Botox is going to be spread from injection site. And this is not just in the bladder, but anywhere there's a Botox injection. If they're swallowing or breathing difficulties, they can be life-threatening. Contraindications. If there's a pre-existing infection at the injection site, UTIs or urinary retention. So this isn't if a patient has incontinence with retention, this would not be an indication for that patient. Adverse effects are UTI, urinary retention, and dysuria. Monitoring, you need to check post-void residual volume, and then, of course, keep track of the symptoms of overactive bladder. Some notes about Botox. Potency units are not interchangeable, and prophylactic antibiotic therapy 1 to 3 days prior to 1 to 3 days after the injection. Interactions. Aminoglycosides or aminoglycosides, potato, and drugs affecting neuromuscular transmission can increase adverse effects of Botox. So when you do prophylactic antibiotic therapy, do not choose an aminoglycoside. All right. The next slide is nocturia treatment. The only FDA-approved treatment is desmopressin, which is an antidiuretic hormone analog that temporarily decreases urine production. It's administered before bed. Different forms are tablet, sublingual tablet, nasal spray, and injection. And a note about the sublingual tabs, the female dose is half of the male dose. Box warning is severe, life-threatening hyponatremia. Hyponatremia is low sodium just in case. Contraindications for desmopressin are going to be patients with an increased risk of severe hyponatremia. A few causes are chronic kidney disease, electrolyte imbalances, and loop diuretics. There are other causes. Patients with an increased risk of fluid retention, such as uncontrolled hypertension or heart failure. Do not use the nasal spray if you have any nasal conditions. This is a warning. And then adverse effects of desmopressin are hyponatremia, headache, hypertension, and then the Nocturna brand can cause xerostomia. Monitoring, we need to check the serum sodium. There needs to be a baseline, and then at 1 week and at 1 month. All right, some key counseling points. Anticholinergics can cause dry mouth, constipation, and dizziness. The dizziness is why this medication is on the Beers list. Avoid mouthwashes with alcohol to avoid dry mouth exacerbation. Next, we have oxybutynin XL or ditropan XL. It can cause not a ghost table, but a ghost tablet in the stool. And we went over this in one of the earlier sessions. Excuse me. The ghost tablet, basically the medication that's in the tablet has dissolved and has been distributed, but the the actual shell of the tablet is still remaining. So you counsel the patient, as long as the shell is empty, do not be alarmed. Oxytrol patch, you open one patch and apply, oh, one pouch and apply one patch to clean dry skin on abdomen, hips, and buttocks. You apply a new patch twice weekly, and every time you apply a patch, you'll select a new site. You want to rotate the sites every 7 days. And then, of course, desmopressin, we talked about hyponatremia. All right. So, that's going to be the slides. I have 3 practice questions today for these topics. And if you're new, I'll read the question. And then at the end of the reading, put your answer or answers in the chat. And then we'll discuss the question as we go. All right. So practice question 1 is, which of the following medications works by antagonizing muscarinic receptors in the bladder? A. Ditropan. B. Phenazopyridine. C. Myrbetriq. Or D. Flomax. All right. So we have some answers, and the correct answer is A. So good job for everyone that responded. I put the generics in the parentheses, and B, I think, is the generic, and we should get the brand name. So, in the resources, Suspicious Bunch has linked a really good resource for the top 300 brand names. Uh, it used to be 200, but the formulary and the high yield list has expanded. So definitely look at the top 300 brand names. So the correct answer is A here. Oxybutynin is an anticholinergic or antimuscarinic medication used in the treatment of overactive bladder. Excuse me. So tamsulosin is an alpha blocker. Myrbetriq is a beta-3 adrenergic agonist, and phenazopyridine is going to be a urinary analgesic over the counter for UTIs. Anyone have any questions or concerns for practice question 1? All right. Next, we have practice question 2. RG is a 55-year-old male, presents to your pharmacy with a new prescription. He tells you about his recent problems that resulted in his urologist prescribing uroxetrol for the treatment of BPH. Past medical history is diabetes type 2, hypertension, hyperlipidemia, and depression. Current medication list is going to be metformin, extended release 750 PO mg BID, Mounjaro 2.5 mg sub-Q once weekly, Lotensin 20 milligrams POQD, and Microzide 12.1 mg POQD, Lovalo 2 milligrams POQD, and sertraline 50 mg POQD. Which of the following statements are correct regarding uroxetrol? Select all that apply. Remember, one can be correct, all can be correct, and anything in between. Take with food to increase absorption. Choice B, monitor blood pressure while on uroxetrol therapy as it can decrease blood pressure. Choice C, uroxetrol is a 5-alpha reductase inhibitor that works by shrinking the size of the prostate to relieve BPH symptoms. D, there is significant interaction with sertraline that can possibly lead to serotonin syndrome. And choice E, uroxetrol tablets may be chewed or swallowed. And while you take your time and answer the question, if you're new to the session, you're not sure, you can guess. You can also put a question mark next to your choice. I always recommend if you're unsure about any topic, make sure you make a note, and either after the session or tomorrow for sure, you go back and you review this material. It will help you remember. While we wait for some more answers, this question covers area 1, 2, and 3 of the Naplex. And area 1 is obtaining, interpreting, assessing data, medical or patient information. Area 2 is identifying drug characteristics. And area 3 is developing or managing treatment plans. I have a couple answers. Anyone else want to choose? All right. So let's discuss this question. So A is correct. Taking uroxetol with food allows for increased absorption of the medication. So if you chose choice A, good job. Next, choice B. B is also correct. Monitoring blood pressure is important for uroxetrol as it can cause decreased blood pressure, especially if taken with other antihypertensive medications. The effect on blood pressure should be less than more nonspecific alpha 1 antagonists, such as doxazosin or prazosin. So, patients taking Lotensin, we definitely need to be careful and monitor blood pressure. So, choice A and B are correct so far. C is incorrect. Because uroxetrol is an alpha 1 adrenergic antagonist. It relaxes smooth muscle tone to improve urinary flow and improve the lower urinary tract symptoms. Remember, alpha blockers do not reduce the size of the prostate. However, 5-alpha reductase inhibitors like dutasteride and finasteride do decrease prostate size in the treatment of BPH. All right. So choice D is incorrect. There is no clinically significant drug interaction between those two. And last but not least, E is incorrect. Uroxetrol is an extended release tablet, and you don't want to chew or crush. The generic for uroxetrol is going to be alfuzosin. Alfuzosin. Good. Those of you that attempted it, or if you wrote the answers for yourself, great job. Did anyone have any questions or concerns about practice question 2 that touches areas 1, 2, and 3? All right, and if you think of one later, we can always address it then. No problems. Now we have practice question 3, the last but not least, and this is going to be a woman comes into your community pharmacy to pick up her mother's new prescriptions for ibuprofen 800 mg PO Q8 PRN and Myrbetriq 25 mg PO QD. You see on the patient's profile that they are also taking Caspargo Sprinkle 50 mg PO QD and Coreg CR 10 mg PO QD. The woman says she is a caretaker for her 85-year-old mother who is recently struggling to swallow pills and will be undergoing a swallow study next week. She wants to know which of her mother's medications she could crush or open for capsules without crushing internal contents to make it easier on her. Which of the following medications would you tell the woman would be permissible to crush or open if a capsule without crushing internal contents? Select all that apply. So choice A is ibuprofen, choice B is Myrbetriq, choice C is Caspargo Sprinkle, choice D is Coreg CR, and E is none of the above. Remember, this is select all that apply. All right. Anyone else want to try? Remember, this is a place to try. If you get it wrong, it is okay. Getting it wrong on the Naplex is the wrong place to get it. So, good. We have some answer choices. So the correct answers are going to be A as in apple, C as in cat, and D as in dog. So let's see why. There are medication specific instructions, and there's a few that we normally know you can't. Extended release tablets, sublingual tablets, medications that taste foul or irritating to the stomach, effervescent tablets, and those that are potentially hazardous. Those are usually guaranteed. Those are a safe bet not to crush or open. Now, ibuprofen tablets can be crushed and mixed with a small amount of up to 10 ml of water or liquid that the patient can swallow. They may have a foul taste, And then there's also, as an alternative, an over-the-counter ibuprofen suspension. I believe bubblegum flavor is available. However, ibuprofen is not optimal for this patient due to the age and the risk of toxicity. Two toxicities we worry about, GI bleeding or nephrotoxicity with NSAIDs. And this is according to the Beers criteria. So it may be something that you bring up and switch. Next is mirbetriq. As you know, this is a beta 3 adrenergic receptor, and it is an extended release tablet, should not be crushed or split, swallowed whole with water. All right. Now let's talk about choice C. Many of you chose it. It is an extended release capsule of metoprolol succinate, and even though it's extended release, Sprinkle should have given it away. The capsules may be opened and placed in a teaspoon of applesauce pudding or yogurt. You do want to administer it within 60 minutes of mixing it with the soft food. You don't want to store it for future use. All right, last but not least, Coreg continuous release is a capsule of carvedilol, and the insert states that the capsule may be opened and sprinkled on a spoonful of applesauce, making answer choice D correct. So once again, A, C, and D were correct. After taking the Coreg CR with applesauce, patient should drink fluids to ensure the full dose is completely swallowed. So there is a star for Coreg CR. Does anyone know what dose dumping is and how it applies to Coreg CR? And if you don't know, that's okay. I will give you a hint. If you know what dose dumping is in general, I typed it into the chat. So, dose dumping is when your body essentially there's gastric emptying and all the medication is released all at once. Coreg CR should be avoided within 2 hours of any type of alcohol to avoid dose dumping. Okay? Coreg CR is formulated to give a continuous effect. If it's released all at once, it may result in hypotension. But dose dumping is a general concept for you to know. All right. So that ends. That's the last question that I have. Did anyone have any questions or concerns about the practice, the presentation today, the Naplex in general, the MPJE? Any questions or concerns that I can answer for you? If you are interested in tutoring, you can send me a DM. And like I mentioned at the beginning, I should, in a day or two, have a schedule for group sessions along with timings. Just as a note, there is a survey. Please fill it out so we can use your feedback to improve these sessions. I am happy to help in any way that I can. Did anyone have any questions or concerns? All right. If you think of one later, my DMs are open. Have a great evening, everyone. Keep up the good work. Put your best effort forward, and you will get the result that you're looking for. Have a good evening, everyone. You're welcome.